Welcome to Quality and Safety in Healthcare. Today we're going to talk about workforce safety, and I'm sure many of you have experienced some aspects of workforce safety already, especially with the advent of COVID-19. There's been many articles and experiences in the news and workplaces around PPE and other supports that our healthcare workers need to do their job safely. So we're going to take a look at some of those underlying issues today, and I think we'll be studying the COVID-19 issues for many years to come. So when safety emerged as a discipline really in 2001 in healthcare with the Institute of Medicine report, over time, it was apparent that workforce safety is linked and essential for patient safety. So basically, you have to have a healthy workforce to take care of patients to get quality outcomes. And that includes safety, morale, and wellness, all of those things, not just for nurses, but for physicians, medical assistants, pharmacists, physician's assistants, anybody that you can think of that's a part of the healthcare team. Unfortunately, healthcare hasn't had a stellar representation and outcomes. There's lots of work-related injuries, a little higher than most other occupations. And some of that has to do with back injuries, blood exposures, things like that. And also, over time, workplace violence has emerged as an issue as well. And I think we've read some of the articles around that. So basically, to provide quality care, workers need to feel appreciated and sometimes not only appreciated but safe to do their jobs. So one of the issues of workforce safety is staffing and nursing. And actually, this is one of the few areas of safety that has peer reviewed research, and you'll see that in your readings, that shows an association between staffing and education and patient safety. Also shows links to burnout, turnover, lots of things. So one may question, if we have actual evidence, why don't we have the best staffing everywhere? And usually it boils down to a budgetary issue. Staffing is scrutinized in every budget. It's the highest budgetary outcome. So the magnet program, which certifies hospitals as stellar institutions for quality outcomes, includes staffing as a quality outcomes. And also some unions have tried to tackle staffing through standardized staffing numbers in California. And actually, there's some good reviews in your articles. Take a look at that. But staffing is really key to quality care, and there is science associated that. There's a new white paper in your readings as well that pairs nursing with chief financial officers to look at staffing. And even in states with mandated staffing, there's still some issues around that need to be worked out. So it isn't perfect. So this actually is from the Begley white paper, and you can see some performance metrics around patient outcomes. And then there's also efficiency measures that most hospitals measure that are linked to financial performance and drive outcomes, like length of stay is something you'll see how many days patients are in the hospital, the full-time equivalents per occupied bed, OR turnover, how quickly are they getting people through. These are efficiency numbers, but one thing that's super important is staff retention. So related to turnover, backfill and recruitment costs. There's some surveys around. I think the last one I saw was actually a study that said it costs about $67,000 to replace a nurse with orientation costs and other things. So if you have a high level of nursing turnover, you don't have an established staff. Now, it's good to have some turnover, Usually under 4% is a good rule of thumb, although you might see it different in other pieces of literature. So you want some new people coming in to bring new ideas and thoughts, but you don't want an unstable staff where the turnover is high and equilibrium can't be reached. So patient outcomes are the quality metrics. These efficiency metrics also are usually in the financial bottom line, but in terms of staffing, that staff retention is very important. So what impact does nurse staffing have on outcomes? So we see from the literature, patient satisfaction, quality of life, decreases in medication errors, decreases in mortality, hospital readmissions, length of stay, and so on. Now, if you have the right skill mix, that can reduce patient costs over time. And actually, there's software even that looks at staffing, but one of the challenges is measuring exactly what a nurse does, because so much of the things that we do, and remember back to Dr. Ebright's talk about the invisible work of nursing, is tough to measure. And holding a patient's hand doesn't always lend well to translation to software. So it's an inexact science, but there is a science around it. So something to pay attention to. And when you're looking at a place to work, it's a good question to ask what the turnover rate is, as well as some of their outcomes that they're experiencing, whether they're going on the magnet journey. That shows that they have to report some metrics around staffing, and things like that. So here are the care unit specific factors that impact delivery. And this again is from the Begley white paper, which is a really good synthesis of some of the current literature. So patient turnover, number of admissions, discharges, transfers, how busy the unit is. If you're thinking about the Vanderbilt case that we're taking a look at, that nurse was taking a patient to off-unit diagnostics. How many patients are off the floor at any one time? What's the unit geography? Is there any language needs? And what's the team composition? And so building interprofessional teams is extremely important. And the other thing to note is nursing actually, as I mentioned, has been studied pretty extensively for staffing. Much work needs to be done, but there hasn't been that much work done in other areas of discipline. One exception is medical resident training hours, where a few years ago they limited training hours in the US, and it really hasn't shown a positive link to quality outcomes. But common sense would show, and maybe a correlation to nursing data, if you've been on call for 24 hours, that your accuracy probably would go down. There might be some other literature out there. I've seen some things around pharmacy staffing. I've not seen anything yet around physician assistant, but this is an area that really needs some more study. So staffing links to many things, quality outcomes. If you're a nurse manager, you're interested in all of these things, your turnover, how are you retaining patients, the unit culture, all of those things adds to and contributes to stable staffing. Now, one other thing to mention is we're talking mostly about hospitals here. So other care venues aren't as well studied. Long-term care, hospital clinics. So most of the work has been really centered on hospital care settings. Now, one of those areas that contributes to staffing as well as workplace safety is burnout, and it's been getting a lot more attention in recent years. And burnout is really a combination of exhaustion, cynicism, and inefficacy resulting from long-term job stress. And so there's some figures around this from an article by Reith. It shows about 50% of physicians experience burnout, with ED and OBGYN more experiencing higher levels, and female physicians experiencing higher levels of burnout too. Nurses and PAs show about 40% of the nurses experience burnout, and residents and medical students from 50 to 75%. So burnout is a recognized area. The problem is it's a very difficult area to address. So this is an older study, and here are some of the job stressors that affect workers' health: long work hours, overload and pressure, lack of control over work, lack of participation, poor social support, ambiguous management and work roles as well. Now, physician or nurses, and this is a very old study from one of my old human factors textbooks, but nurses related job related causes and stressors to high workload and the effect on personal life, staff shortages, unpredictable staffing and scheduling. So you can kind of see that dovetailing there. Lack of time for providing emotional support to patients. Now, this study was done in 1998, really before the electronic health record. So probably a more current study would show, I would think, even more decrease in emotional support to patients. And then poor leadership too. Leadership is a whole nother area that you guys will study that really can bring these pieces together to prevent burnout and staff deficiencies. So physicians, on the other hand, their stressors include a high workload, pressure at work, and low organizational justice. And actually, in interdisciplinary teams, do pay attention to how other disciplines work, whether it's a phlebotomist, a physician. I mean, when you look at surgeons and balancing off office hours, surgeries, off-hour support, it's a lot, and nurses are on call as well. So do pay attention to how everybody works for a couple of reasons. One, it's interesting to know as a part of a team. I think it can make a stronger team. But two, I'm hoping you guys will be able to come up with some solutions during your careers. So burnout solutions are difficult to address. It's just a hard area because sometimes, even if you do everything right, people will get burnout. So leadership, a wellness officer, encourage solutions and mean it. Certain incentives work, but not all. It's not something you can just throw money at. Sometimes people feel a little better after a raise, but it doesn't last for long. Work-life balance is so hard to achieve, but it really needs to have some sort of balance in there that you're comfortable with. Some people are comfortable with getting calls on off hours. Some people like to leave it separate, and these are things you'll have to juggle and when looking for your positions. Peer support, mental health support, and it needs to be addressed from day one. Now, workplace safety is another issue, violence, those sorts of things, and we've seen some scary cases in the last few years. Supportive work environment is another thing, and effective reporting. Really, workplace violence is very underreported. Sometimes we wait until it's too late because we like to think the best of people. And so ANA did take a position, and many workplaces have initiatives in place to address workplace safety, although not enough yet. So this is a very important area. Just a few thoughts. Again, take a look at this. Do look at your current work environment, where you want to work, what leadership is saying about staffing, burnout, workplace safety. And then also, as a professional, think about how you can help create a good environment, find a good spot for yourself and address some of these issues as time goes on. Have a good week.